So Mark, I will just quickly give a general welcome and then turn it over to you. Just as a note, we're not seeing the slideshow view. So before you get started, if you want to flip it to that. So welcome everybody. It is exactly 12:30. We'll try to be mindful. Oh, I'm sorry. It's not. We're a couple minutes ahead, aren't we? I'm looking at my computer time. So we will maybe take another couple minutes before we kick it off. So we'll continue to welcome everyone and let you introduce yourselves in the chat. I will continue to refer to the iPhone time. I think that's probably the most accurate. Thank you to everyone who's introducing themselves in the chat. Hi, Cassie. Thanks for joining us. Glad to have you with us. If you haven't done so already, feel free to introduce yourself in the chat and let us know where you're joining from, what practice or program. And we will go ahead and get ready to get started. I've managed to figure out which clock to attend to, so I now am oriented to the time, which feels like an accomplishment on a Friday afternoon. So
it's a lot of buttons and dials in doing these.
Yes, there's a lot to monitor. Exactly, Mark. So I will just go ahead and give a brief introduction and then turn it over to Dr. Fishman to fully introduce himself and kick us off for this afternoon. But I'm Kelly Coble, the program director for Maryland BHIP and MACS, the Maryland Addiction Consultation Service. And we've done a few of these joint events. We're excited to have Dr. Fishman back for a kind of blended BHIP and MACS webinar today. And we're excited to hold this one during Recovery Month. So I will not hold us up any further, but if you have questions about our services, some of our team members will be monitoring the chat and can answer questions. But we'll hand it over now to Dr. Fishman. Thank you again for joining us and leading us through this next hour.
Terrific. Well, thanks for that intro. And what we're going to be talking about today are young people with the overlap of use of benzodiazepines and or prescription stimulants, and considering what the implications are for SUD and substance use. One of the things that's particularly interesting, impactful, and vexing about this topic is that it's an intersection of potentially therapeutic agents, agents that have a role in the repertoire and the armamentarium in the tool chest of practitioners, but that have problematic side effects, that have implications for potential diversion, potential exacerbation of substance use disorder, for potential addiction, and thinking about when and where and for whom to use them and how, and then thinking about people who we do see who have disorders in the use of either or both of these substances, and thinking about how to approach them clinically. So that's the broad outline. Just a word about conflicts. I've had some funding and been a consultant for a variety of private interests. I think the one that's maybe most relevant is from Alkermes, who you may know is the manufacturer of extended release naltrexone, which is a therapeutic agent for opioid use disorder. I don't think that biases me, but you guys will be the judge. And here's how we'll approach today's conversation. By the way, it seems like a small group, so hopefully we'll have time for discussion at the end. If you have questions along the way, put them in the chat. I'll try to make sure we get to them. I'm going to try to make this conversation as practical and clinical as I can. And I'll say at the beginning that lots of what I'm going to be saying and talking about is based on emerging clinical consensus rather than lots and lots of really good science, especially on the therapeutic side, because it just hasn't been studied well enough and we don't know well enough. So lots of room for further research, but in the meantime, we've still got to treat patients and use the clinical information at hand, and I'll be trying to distill that in as practical and approachable way as I can. So I'll give a little, I'm going to divide the talk into the two sections, one on benzodiazepines and one on prescription stimulants, both agents that are widely used and misused in young people. When I talk about young people, I'm referring both to adolescents and young adults. So 14 to 26, I don't know, some people might say adolescence goes on into the 40s, I'm not sure. But one way or the other, the idea is we're not talking exactly about a chronological red line cutoff. We're talking rather about a developmental stage that has many vulnerabilities that you well know about in a developmental way. That convey both the richness and the difficulties of this period in the lifespan. So we'll talk about some of the background for each of them, scope of the problem, some epidemiological trends in use, talk just a little bit about what the agents are used for, but focusing a bit on what some of the problematic aspects are in addition to the therapeutic aspects. Talk in particular about the potential therapeutic use, particularly the psychiatric use for these agents for patients with co-occurring disorders, that is, who are substance users, who are people who are youth who are at risk, either for developing a full SUD or already have an SUD, thinking about what the implications are, how these patients should be approached. Talk a little bit about the treatment of such patients who've already developed a full substance use disorder on these particular agents. So in general, thinking about people with substance use disorders writ large, for youth, that's going to be mostly, as you well know, alcohol and more so even cannabis and nicotine. But there are a subset of patients who actually have use disorders with these agents, that is addiction or use disorder with benzodiazepine, use disorder or addiction with prescription stimulants. So talk a little bit about how to approach those patients and try to organize some of the conversation around some case illustrations and then perhaps end with some conclusions. So let's start with benzos. And when we talk about benzos, they will be the most common example of a broader category of the sedative hypnotics, but by far and away, it's the benzodiazepines these days that are most common. before there were benzos in the 60s, there were other sedative hypnotics. Most of us don't remember the days of Milltown, meprobamate, the phenobarbital and other related agents. Mostly these days, it's the benzos, and alprazolam is the one that is probably the most vexing, as we'll return to. And just to frame it, let's talk about a potential case for you to have in mind, and then we can come back and discuss this and related cases in more detail. Hypothetically, or in a composite way, you've got a 20-year-old young woman. She's been using cannabis and alcohol since her early to mid-teen years. Let's call it 15. For some people, that'll be earlier. For some people, that'll be late. But that's, right in the middle of the typical age of onset, and has had progression to problematic use. But in addition to that, she's had comorbid affective disorder with symptoms of depression, anxiety, panic. And over the years, starting, say, in her early or mid-teens, has had some intermittent episodes of treatment. Those have included some therapy, some intermittent use of antidepressants, some intermittent use of alprazolam. You guys know that's the generic name for Xanax. And none of those episodes of care have, in retrospect, been sustained or dramatically successful. She's had erratic adherence, sometimes showing up, sometimes not, sometimes taking the pills, sometimes not. Although there's usually not a lot of trouble adhering to the alprazolam, right? That's the one medicine that people don't forget to take. And she, anyway, fast forward, here she is 20. She's in some kind of crisis, and she's feeling miserable. And she says, listen, I've tried everything. Nothing works except Xanax. That's what I want. That's what I need. And we can come back to and discuss that. So let's talk about some use trends. Benzodiazepines are very common in the US. It's surprising, right? 12 to 15% of US adults, that's individuals in the US over the age 18, are taking a benzo. Maybe not every day. Many people are prescribed them intermittently. Many people are prescribed them in short bursts for time-limited potential therapeutic benefits for anxiety, for insomnia. And that is increasing. In the last 2 decades, it's up nearly 70%. So lots of medical use, but lots of non-medical use, and both are increasing. Just to give you some sense of that, of the people who use benzodiazepines, 20% of them have misuse, and misuse can range anywhere from taking more than prescribed with medical use to getting them from another source and using exclusively non-medically. A lot of people have mixed medical and non-medical use. That's not surprising to you. And although 20% is the average across the lifespan, you won't be shocked to hear that it's vastly higher in young people. So 50% of the young adults who take benzos have had misuse. One of the things that's very important to know about benzos in thinking about their dangers, and you will sometimes hear people trying to remind us that while we're also focused, as we should be, on the opioid epidemic and the crisis that's occurring, and including the increase in opioid overdose trend over the last couple of decades, this somewhat less publicized or more hidden epidemic at a lower scale, but still quite important and dangerous, is sedative hypnotics, especially benzos. And estimates range from between a sixth and a third of opioid overdose deaths involve co-use of benzos. And while there are certainly benzo deaths that don't involve opioids, and in particular, that next second category would be the mixture of benzodiazepines and alcohol, fully 85 to 95% of benzodiazepine involved overdose deaths also involve co-use of opioids. So it's a very dangerous combination. Just looking at different use patterns across the lifespan, here's the last recent number of years looking at trends in misuse. And you can see that young adults are per capita disproportionately represented as that group that has the highest rates of misuse. Adolescents, 12 to 17, are closer to the general population. There's been a little bit of a downturn in the last sets of data. This is from the National Survey on Household Drug Use, but those aren't statistically significant. So the difference between 2018 and 2019 is not statistically significant, but it's at least good news. And it looks like there was a downtick, at least in young adults, between 2017 and 2018. But we try not to get too excited about one year compared to another year, unless there's reason to think that there's some real validity to it. But the notion is that we're holding steady at fairly high rates. Here are emergency department visits involving benzodiazepines, and we're seeing them both for people who use benzodiazepines without other substances and those who use with other substances. And benzodiazepines alone, although they're not responsible for as many overdose deaths, still have considerable medical morbidity associated with them. So more people are going to the ED for acute intoxication problems with benzos alone than they are with mixtures, although, as I said, it's the mixture of benzodiazepines and opiates that results in the most serious rates of overdose death. And after benzodiazepines and opiates, benzodiazepines and alcohol, and then the triple whammy, benzodiazepines, opiates, and alcohol. Lots of our patients are polysubstance users. But these trends are in the northerly direction, right? Things are increasing in their severity. And the saddest part, right, the most severe end of this morbidity spectrum is mortality. So here are benzo-related overdose deaths. This is not just young people, right? This is all people over 18, and that would reflect more people who are older adults, both because there are higher rates of death among older adults than there are among younger adults, and because just in an aging demographic, there are more older adults around. And you can see that these numbers are increasing. The pandemic, as you may know, has made things all the worse. Between 2018 and 2019, we saw a glimmer of hope with opioids and a downtick for the first time in a couple of decades in the opioid overdose death story. But then the pandemic has set things ablaze all over again. And so the same is true for benzos, along with the broader trend of pandemic-related overdoses and overdose deaths. Benzodiazepine OD and benzodiazepine OD death has gotten worse. And I know I said before, don't get too steamed up about 1 year change. It could be noise on the graph. Here's an exception to that because we see the trend across many drugs. We see it clinically. We have a reason for it, likely increased despair, the stressors of the pandemic, decreases in social connectivity, or rather increases in social isolation, decreases in the availabilities of services, et cetera. So OD deaths related to benzos up 24%, and that is attributed both to prescription medical use and to non-prescription non-medical use. And the 520% increase 2019 to 2020 in non-medical use OD deaths in benzodiazepines is pretty shocking. Still, the numbers are way lower than opioid use disorder deaths and lower than alcohol use disorder deaths, but still pretty alarmingly high. So just let's talk a little bit about the benzos. As I said before, alprazolam or Xanax is a short-acting agent, and short-acting agents are typically the ones that are most misused. You get the most speed of onset and speed of offset. That's the feature that is most reinforcing in drugs of misuse. But others also, clonazepam, Klonopin, diazepam, Valium, Zolpidem, Ambien, which is not a benzo pharmacologically. We call them sometimes Z drugs because although they're not pharmacologically benzos, they work at the same set of receptors and have the same mechanism, so they're the non-benzo benzos. But anyway, many of these are also diverted and misused, but alprazolam the most. They are often, as we've said, used in polysubstance combination. We talked about the dangers of combination with opioids and with alcohol, and this common problem of mixed non-medical and medical use, including doctor shopping, in the same way that we're all too familiar with in the earlier phases of the prescription opioid epidemic. So what are the characteristics of benzodiazepines? Whether used medically or non-medically or both, they are very reinforcing, right? The patients really like them. They make people feel good, and they do that with both positive and negative reinforcement, right? The two components, positive reinforcement being that you get a euphoric feeling, you get a buzz, you get a high, but also negative reinforcement, meaning the relief of a negative experience. They are relieving of distress, whatever that distress is from, whether it's from a concurrent psychiatric disorder, whether it's from anxiety, whether it's for the stressors of the day, whatever it is, like alcohol, benzodiazepines are immediately and compellingly reinforcement for their sense of giving people relief. And I think that analogy to alcohol is very, very useful, both to us as clinicians, but also to our patients. I use the metaphor that it's alcohol in a pill, or when I think I can get away with the joke, I say it's a martini in a pill, but I prefer getting the olive. You don't get the olive with the pill. But one way or the other, the notion is that the pharmacological mechanism is very similar. So anything that you might expect with alcohol, whether it's a positive effect or a negative effect, you can expect with a benzo. And that's a very kind of helpful way for people to get their heads around what these things do. The thing is that although they are relieving, that relief is very short-lived, and it is typically non-sustainable. There are exceptions, and we can talk about the therapeutic benefits of benzos in a patient population that doesn't have comorbid substance use. But the development of tolerance, especially in the other substance using population, with ensuing dose escalation, is the rule rather than the exception. And so patients tachyphylax to that sense of relief. They need more, they want more, they vote with their feet, and they get more. And there are side effects, potential side effects at all doses, and we can talk about that, but not surprisingly, with dose escalation, the predominance of side effects escalates. So what are those side effects? Well, it's intoxicating. And we can talk about that as being therapeutically beneficial in the same way that we think that for people who can manage it, who don't have loss of control, who don't have substance use disorder, back to the analogy of alcohol, you had a hard day and you have a glass of wine with dinner. Many people use that as a coping mechanism, but the people who are able to not be impaired use it as a minor, occasional coping mechanism. They're able to have one, not two. They're able to have one occasionally, not as the rule, and they don't dose escalate. Loss of control is a hallmark of developing progressive substance use disorder signs and symptoms. But remember, the benefit is the same as the side effect, that feeling of intoxication. That's what causes the relief, that blissed out, I don't care, devil may care, I don't notice the pain kind of intoxication. And sometimes that's subtle with low doses. In clinical cases that many of you have seen and that I take care of every day, it's not so subtle. People are falling down drunk on benzos the same way they might be falling down drunk on liquor. But even when it's low doses, there is this kind of subtle clouding that includes disinhibition, that includes cognitive impairment, and you may notice it, but in higher doses, you will certainly notice it. Another thing that is typical is affective instability. That's true of alcohol as well, right? But people's moods become changeable. Some people are ornery, angry drunks. Some people are weepy drunks. Some people are goofy, loud, ebullient drunks. But all of these are features of affective instability, and the same thing that applies to alcohol applies to benzos. Another important feature is while they are relieving of distress and especially anxiety, there is a very significant rebound effect. So by contrast, in the on state, under the influence of these agents, there's a sense of peace. And then when you're off them, by contrast, the distress, the anxiety is magnified. And that happens in two ways, both by contrast, that is the on state versus the off state. And then it also happens as you develop tolerance and withdrawal. And then the withdrawal features, like with alcohol, include anxiety, insomnia, distress. And that feels like the world is a more anxious place when in fact the world for many is a benzodiazepine absent place, and benzodiazepine withdrawal, as we'll talk about, looks like a mood disorder, looks like anxiety disorder. And another way of saying that is a benzodiazepine induced anxiety disorder, and that's part of this phenomena of rebound. And physiological dependence and withdrawal can come relatively quickly. In a matter of just a few days, there's heterogeneity in the population. It varies from person to person, but people who are on pharmacological doses, physiological doses of benzos, can have modest physiological dependence in just a few days. And you will often see patients who've been on them for years, and that's a much more intractable problem. So it's important to talk about anxiety. Many of the patients who are using benzos will present with complaints of anxiety. That may be the reason they got started, or as they're experimenting with them and they like the euphorogenic approach impact, they may also like, as I said, the negative reinforcement of relief of anxiety and other negative affective states. So it's important to talk about anxiety, and many of the patients who come seeking benzodiazepines will talk about, I have an anxiety problem. I need these for my anxiety. So I think some conceptual issues are helpful. For these patients, I think in general, it's helpful to think of anxiety as a symptom rather than a disease. The patients will try to, they won't use these, or they won't articulate it in the way I'm about articulating it, but they will describe it to you like, I have this monolithic diagnostic entity called anxiety that must be treated in this way. And it's not like pneumococcal pneumonia, right? It's not like a clear disease of known pathophysiology. It's a symptom, and anxiety can be caused in a gazillion different ways. And in general, I think the best way of thinking about it is as a feature of a broader category of affective disorders, whether those are major depression, whether those are the particular anxiety disorders, whether it's generalized anxiety or it's OCD. In general, these are patients that are broadly affectively dysregulated and destabilized. And anxiety may be one of their prominent symptoms. If you dig, there's plenty of others. They may be irritable, they may be sad, they may be angry, they may be labile, they may have anhedonia, they may have insomnia, the full range of things that they have. But I think it's helpful to think of it as a symptom and as a symptom of many possible different disorders with a broad differential. Another thing that patients tend to say at the door is, doc, you don't understand, I've tried everything and nothing works except Xanax, alprazolam. But when you dig deeper, and it's essential that you do so in assessing these patients, everything means different things to different people. When you say you've tried everything, let's actually go over the catalog. And when you say you've tried, does that mean you took one pill? Does that mean you were given a prescription that you didn't fill? Does that mean that you took it for 5 days and when it didn't work or caused side effects, you gave up on it? Does that mean you took it while you were using benzos? Does that mean while you were using other intoxicating substances? So again, everything in quotations. And I think it's important to, again, frame this very compelling, very salient sense that patients are firmly committed to. It's not that they're lying. This is their experience, that there is nothing else that gives this immediate relief, right? One of the things that we can talk about in terms of the broader repertoire of tools that are, in our view, generally, and the evidence supports, are more definitive and more sustainable, they are vexingly slow. It's like many of our treatments in psychiatry, right? You're suicidal today, and I say, well, I'm going to give you a treatment, and maybe in a month you'll feel better. Yikes! Well, that doesn't help me today. And so no wonder patients are compelled by that. But that strategy is non-sustainable, but that's not what they see, right? They have nostalgic recall for peak intoxicating levels when they were blissed out and didn't care, and that's what they want. And you can't blame them. But the other thing that they will say is that I know that you're not going to give me these, or won't want to give me these, or have singled me out, and they'll make you into a stigmatizing bad guy because I have a substance use disorder. But I swear that I've never misused. Maybe yes, maybe no. But I think that for me, both because I think it's the more important thing, and I think because it's a more persuasive conversation, is to talk about the characteristic side effect profile rather than talk about the risk of diversion. I'm not going to get into a fight with you about whether you're going to divert or not. I'm not going to get a fight with you about whether you misuse or not. I'm not going to get in a fight with you about whether you're going to escalate or not. That's not the point. The point is that there is this characteristic side effect of benzos with worsening rebound anxiety, cognitive impairment, subtle or not so subtle intoxication, that worsens the course of mood disorders, of depressive disorders, of anxiety disorders over time, rather than makes them better. So the reason that we might need to have this conversation about whether these are for you or not is not necessarily because I have mistrust for you. It's because these aren't good for you and I have better stuff. And as you guys know, the classic is the combination of an SSRI, sometimes other members of the antidepressant class, but typically we start with SSRIs, plus cognitive behavioral therapy. And it is remarkably effective, but it takes time. The other thing that the patients say is, when you say this medicine, what kind of medicine is it? Well, it's antidepressant. I don't have depression, by which they mean I am not sad, right? Because in our common language, small d depression gets confused with big D depression, and a lot of people have the misconception that depression is primarily a problem of sad mood. No, depression is a problem of many different dysregulated moods, including anxiety. So I'm not going to have the fight with you about whether you have depression or not. You have this problem, anxiety, whatever you want to call it, and these medicines are good for that, but unfortunately they take time. And then the other thing that is so important to include in our tool chest, which is typically part of the CBT, but can't be emphasized enough, is that you need to help patients desensitize to anxiety. That is, they've got to change their threshold of catastrophe. They've got to learn to be more anxiety tolerant. They've got to learn a coping strategy repertoire of learning to self-soothe and to develop tools for stress relief. And especially if these are patients who've had longstanding SUDs, they've missed, in young people especially, they've missed that developmentally. They have not developed the standard tool chest that most of us have. What's the button you can push at the end of a bad day, the end of a bad week, the end of a bad year? And you need to develop that as a mature adult. It might be different for everybody. For some people, it's soft, soothing music. For some people, it's thrash metal played at 20 million decibels. For other people, it's quiet walks in the park. For other people, it's exercise. For other people, it's knitting. Whatever it is, part of the user manual to your own self is learning that, and that needs to be an explicit part of the psychotherapy for these patients. And it's not easy, right? Because they're already up to here in terms of their catastrophization, and nothing can match, again, as I've said, that immediate relief of a benzo. But in the end, and over the long term, the benzo is bad for them. So we see these patients with benzos, and if we can convince them to get off, it is important to think through in a systematic way withdrawal management, because there is considerable morbidity associated with withdrawal. Just as with alcohol, benzos can cause all of those troublesome problems, including seizures, hallucinosis, and delirium. So you got to be careful about it. The other thing is that when patients are miserable and in withdrawal, they know how to treat that on the street with more alprazolam. So you're going to lose them if you can't do it in an engaging way that makes them comfortable and keeps them engaged. So as with most withdrawal management, one principle is switch to a longer acting agent. So you almost never want to taper alprazolam, which you'd have to dose 4 or 5 times a day. So switch to a longer acting agent like clonazepam or like diazepam. For many patients, a couple of weeks of taper is sufficient, but there's a considerable subpopulation of patients, especially those that have been on these agents for years, in which you've got to do a really slow, gradual taper. And that's fine. It's not easy, but it's fine. And if it takes months, that's okay. It puts you in the awkward position of, do you want to be that person who's prescribing the benzos and managing it? But if you are and you want to be in that business, as long as people are moving south, as long as we're making progress, I'm okay. This is not an emergency. If this took you years to get there, we've got time to go down slowly, but you do have to be going down. It is hard for chronic users. There's just no two ways about that. It is difficult, and many patients have fits and starts, stops and starts, and multiple relapses, before they successfully are abstinent from a chronic benzo problem. It's also useful to use ancillary meds, especially the treatment of insomnia, which is a very vexing problem in benzo withdrawal. Trazodone's fine, quetiapine is fine, mirtazapine is fine. Mirtazapine may have the advantage of also, having an anti-anxiety benefit. Sympatholytics like clonidine or guanfacine or lofexidine help with the sympathetic arousal. And using GABAergic substitutes, the most common of which is gabapentin. And gabapentin you should think of in this class of gabapentinoids, with gabapentin being a certain potency, and then pregabalin being the next, and then eventually benzos in terms of a spectrum of potency. They do have their own diversion risk, and some people get into trouble with them, but there is a little bit of an early signal that they can be useful in raising GABAergic tone during withdrawal, and some people even think about them as a maintenance treatment, although there's no real good evidence of that. As these patients can be so tough, consider bed-based care. You may have to start in a bed-based residential or inpatient treatment program. That might not be enough, but you can certainly get them started and then continue it as an outpatient for subsequent weeks or even months. And one of the technical difficulties that we just have to live with, because it's a limit of the technology, is in a long taper that you're doing as an outpatient. You're writing a prescription for the tapering agent. The typical urine drug screen will not allow you to distinguish between the presence in the urine of the metabolites of the benzo that you're prescribing as the taper and any non-prescribed or street benzos. And so you mostly just have to live with that and use your clinical indicators. I think that it's very important to have a very low threshold for the diagnosis and treatment of disorders. For sure, benzo use can cause a substance-induced anxiety or depressive disorder. That is, there can be prominent affective symptoms that will eventually resolve spontaneously in the absence of benzos, but stress eventually. And it can be slow and painstaking for the patient. So of course, you use all the different ways of trying to distinguish, does this person have a variety mood disorder that they had before the benzo, et cetera. But even if the hypothesis is that this person's depression, anxiety is substance in its etiology, because that will tend to resolve quickly, treatment for affective disorder is usually indicated, even if it's short term, right? We usually think of an episode of depression we treat for a year, see what we got. Maybe these substance-induced cases we treat for a whole year, nobody really knows. But in general, these patients, I think, will benefit from being treated for a mood disorder. And you got to shop around for the ones that they tolerate and for the ones that they get some benefit from. And that's, of course, difficult because the gold standard in their view is also always going to be it's not as good as Xanax. So you're always on the defensive. And although there's no real evidence for it, there is some emerging clinical thought that maybe gabapentin, if they can handle it and not divert it and not misuse it, that gabapentin might have some long-term maintenance benefits. So we discussed the idea that people will have trouble with this label of depression. So I don't want to have that fight. People will have trouble with seeing you as stigmatizing them as drug addicts who will misuse these agents. I want to dodge that fight. That's not the problem. It's just that I think it'll make you worse. So talked about that. So let's come back to this case. We have this young woman who's been using other substances. She's had escalation over time. Let's say she's using cannabis most days. She's have binge drinking pattern in the way that young adults typically do, especially on the weekends, weekend stretches and stretches. And she's had this depression, anxiety, panic. She likes Xanax. She wants Xanax. Her view catastrophically is that nothing else will work. How do you engage her? Oh, what is it you do? And these conversations are hard, and these conversations are not 7.5-minute office visits. These conversations may not get traction even the first time you see somebody. You've all probably had this experience. This patient has fired me many, many times. But the good news is, if you keep working at it and you can find ways of engaging people, you can make headway. Anything you can do to promote quick relief, not with a benzo, unless you need to do detox. If you need to do gradual withdrawal, that's one way of getting engagement, and that's fine too. You want to use time-limited short durations with very close monitoring, including UDS. But addressing insomnia, one of the things that we have in our bag of tricks, even though antidepressants take a long time to work, one of the things you can do is treat insomnia and get engagement points for relieving suffering right away. So that's a very important thing to do. And if you need to use alpha blockers like clonidine or guanfacine to help relieve symptoms, and those can be anxiolytic as well. Some people do like relatively benign antihistaminic agents like hydroxyzine. Those are generally fine and safe, and they give the patient some sense of PRN control. Other people say it's not that helpful. Sometimes buspirone can be helpful. I find it especially helpful as an augmentation treatment on top of an SSRI or other primary antidepressant rather than as a primary treatment, but there's certainly data for its use as a primary treatment, and it's worth trying. So I think that it's worth considering some alternate scenarios because the care of such a patient might look different in primary care versus psychiatric care versus SUD care, right? And these are not easy patients. These patients require some time, require frequent follow-up, require a lot of touch. If you can do an integrated model where you have the collaboration of a therapist or other counselor that works with you, that's very helpful because engagement and touch is critical. In primary care, you might be finding that some cases go fine, but other cases they will be dissatisfied and they will need more intensive subspecialty care. In psychiatric care, there's often the ability to do a wider range of treatment for comorbid affective disorder, but there might not be as much technology available for the concurrent testing and for the concurrent substance use disorder, psychosocial treatment and counseling that might be necessary. And another scenario to add to this is, let's say that this person had progressed beyond cannabis and alcohol, but had also been using opioids. Would that change your risk benefit? Would you, if it was just cannabis and alcohol, would you consider the use of low-dose alprazolam? The typical kind of approach to panic disorder for many practitioners, as you know, in non-substance using populations, is sometimes a brief course of a short-acting benzo while the SSRI is kicking in, then tapering off. Would you consider that in a patient who also had comorbid substance use or comorbid substance use disorder? My recommendation is no, and the more severe, the more strongly I feel about that no. I think that the world of patients with mood disorders segregates in those with substance use and at risk for substance use disorders who are more vulnerable to the downside of benzos versus that population you guys may treat. I don't treat them, but they're out there and the data is quite clear. There's a group of patients who will benefit from the use of benzos, especially in short course, but sometimes in longer, more chronic course, without escalation, without misuse, without deleterious side effects. For the most part, that is not this substance using population. And the higher the severity or chronicity or both of the substance use, the more clear that contraindication is. And if there's opioid use, I think the contraindication is very clear, right? We looked at the morbidity and mortality data. That mixture is very problematic, especially in an impulsive group of youth with SUD. So I think that's, for me, an absolute contraindication. Another alternative scenario that we've all seen is, what if the person is presenting to you for psychiatric management, for SUD management, and it turns out that they are continuing alprazolam treatment, but with another provider. And so fractioned care is introduced from the beginning. And by the way, no, you can't talk to my Xanax doctor. What do you mean I can't talk to your Xanax doctor? Of course I need to talk to all your doctors. We're going to collaborate care, and that's what we do. I don't give you permission. Well, then I guess I'm the wrong doctor for you. I mean, it's just not safe, right, to not be able to collaborate with other medical providers. But it is troublesome. And you will find, I'm sure you've seen, that many practitioners who, out of compassionate concern to relieve suffering, have prescribed alprazolam for people who present with severe panic and other mood problems, and they won't know, because the patient hasn't been forthcoming, that the patient has an SUD, that the patient is an opioid.
It seems like Dr. Fishman had a connection issue. We'll be patient for a minute and see if we get him back. In the meantime, if folks have questions or comments, you could start putting them into the chat as we will begin funneling them to him anyway, as we're coming close to the end of our hour. Tracy, if you're able to shoot him a text maybe and see if he could connect a different way, that would be great. But thanks for everybody's patience. I know this is a reality right now of our virtual world, lots of connections happening in the same location. I will keep an eye on the chat if folks want to start entering questions there. There are some logistics entered into the chat about where to obtain your certificate and where resources will be later on. You may also see coming in some links to upcoming events. We tend to hold online trainings through both BHIP and MAX about monthly, and through the MAX program, waiver trainings happen at approximately the same frequency. So if you're a physician that's on with us and you're interested in getting your X waiver, you can join one of our half and halves. Also, we're really making a push this month to go purple and get waivered as part of recovery month. So you can also call our consultation line, and Tracy or another member of our team can walk you through that. Accomplish 8 hours in 8 minutes is what we're affectionately calling it. So our phone numbers will be in the chat, and you can also participate that way if you're interested in prescribing life-saving medication for your patients. Thank you, Bridget. I see the MAX resources added there. Okay, I see some questions for when Dr. Fishman reconnects with us. Thank you, Peggy. And thank you, Natalie. I see some questions there. Thanks, Heather. Okay, we at least have word from Dr. Fishman. He will be back on in a minute. So if you're still hanging with us, thank you. Sorry for the unexpected difficulty. I think a lot of us have been maxing out our connectivity, especially if you have kids learning at home or other things that have come up over this last year. Thanks, Tracy. I see your question as well. So when Dr. Fishman does get back on, I'm going to ask him to jump right to some of these really interesting questions. And if you were not on, thank you, Bridget, for sharing. We've had 2 other webinars with Dr. Fishman, kind of crossover BHIP and MAX webinars that have been really informative. Thank you, Allison and Peggy. It looks like some more questions are coming in. And someone is going to get Dr. Fishman, hopefully just a call back in, just to keep you guys posted. Okay, we're hearing that Dr. Fishman's about to call in. Thank you, everyone, for your patience. Dr. Fishman, did you reconnect? Chelsea or Bridget, do we have to make him a panelist if he just called in, or Tracy said that he is on?
Hello.
Can you hear us, Mark? Can you hear me?
Yeah.
Hi. We aren't sure what happened to you, but we're glad you're back.
Yeah.
And I think we were able to keep most of our group with us, and you have a lot of really great questions in the chat. So perhaps we could just turn to those if that works for you.
That'd be great. Just feed me some questions. And I know we're almost out of time, and my apologies to everyone, but I'm happy to take some.
I think it's very on trend for 2021 to have a tech issue because we've really taxed our system over the last 18 months. Okay, let's see. How about, this question is, how about the use of hydroxyzine for anxiety sleep disorder?
So I think hydroxyzine is squarely on the list. You know, there are some patients that will appreciate it, will find it beneficial either for daytime use for PRN, use for anxiety, or for nighttime use for insomnia. It's relatively benign as an antihistamine, and so I think it's okay to give people access to a supply and let them use it PRN or as a standing HS medicine. You will find some people won't like it, won't think it's helpful, will think it's no good, but well worth trying.
Thank you. You've got a bunch of really thoughtful questions here. This one is, what are your thoughts regarding medication-assisted treatment if patients are using benzos or are prescribed them? So their UTOX would show their benzo use.
Yeah, great question. So I think that it should not be an exclusionary criteria. That is, someone who is seeking care for OUD should be engaged in care no matter what morbidities or comorbidities they have, benzo use disorder included. That just makes the patient more complicated. You know, patients who are sick in other ways because they have complicated medical comorbidities or psychiatric comorbidities or substance use disorder comorbidities still deserve care for OUD. And in fact, OUD being so dangerous and life-threatening, you know, all the more reason, especially with benzos, which, as we saw, complicate the risk of OUD, all the more reason to engage them in care. So the primary approach in such patients is to try to get them onto MOUD, and any MOUD will do, and it's a starting point. But I think the thing to think about there is that you're not done. The goal is to engage them into potentially life-saving MOUD treatment and then work with them to try to get them to come off the benzos because of the added risk. It doesn't have to be a precondition. They don't have to be done with the benzos or cured of their benzo use disorder if they have that before they initiate, but you're clear in your goals that this is our strong recommendation. This is how we think you should proceed. You can take time to do this, the exception being, you know, people who are erratically using, 10 milligrams a day of alprazolam or its equivalent, right? That you got to think about serious safety issues today. But in general, and such a person should still be treated, may be brought into a bed to be able to deal with that. But the notion is, again, we're going to work with you. Let's agree that we're going to wrestle with this issue together. South is the right direction. Doesn't have to happen overnight. I know you don't think it's appropriate for me to talk to your benzo prescriber if it happens to be another provider, but we should do that. But if you don't think it's an emergency, then there's the process of getting to yes, in which, after earning some currency through engagement, you're going to persuade them that your intentions are good and that you have their best interest at heart. But of course, you're going to talk to the other team members on a collaborative medical provider team, including the benzo provider. That's what we do. And it doesn't have to be a deal breaker on day one. And most patients will come around. It's about getting to yes. But there is a point, I can't tell you exactly what that line in the sand is, but there is a point at which it's a deal breaker. If someone says, no, you cannot speak to X, Y, or Z, whether that's my oncologist who's prescribing high-dose opioids, whether it's my methadone doctor who's prescribing methadone and doesn't know I'm using benzos or continuing to use street heroin, or whether it's my benzo doctor, or whether it's my other psychiatrist, you know, whatever it is, medical collaboration is safe and the standard of care, and one way or the other, we're going to do it. And you've got to make your own judgment about how urgent or emergent that is, but it is where you have to go. But I usually am able to do it gradually unless there's, you know, the most extreme urgency of safety. So I don't think it should be a barrier, but it does make it a tougher case. It does make it a very difficult negotiation when patients say, I'm a lawyer up on you, I know my rights. Well, not so fast. Let's just try to work on getting you better and using all the standard tools, and let's see if we can make progress. If you don't like the way I do business, if you don't like my care, you can fire me, but I want to get you better. This is what works.
Thanks, Mark.
That
Maybe,
may sound naive and overly Pollyannish and optimistic. I think that's the way to go.
thanks. Let's see if we can squeeze maybe one or two more in here. Here's a two-parter. I'm interested in what is known about long-term risk for stimulant use disorder in kids needing amphetamine prescriptions for ADHD, and for those young people or young adults with ADHD on stimulant treatment. Is there a higher risk for benzo use or other substance use?
That's a very interesting question, and I am just ignorant. I don't know whether there's any literature on that. I do know that there are patients who, because of the side effect profile of prescription stimulants, sometimes including increased anxiety, insomnia, worsening of affective states, end up on co-prescription with benzos to try to ameliorate that. I worry about that kind of polypharmacy chasing your tail and, increasing side effect profiles. But listen, there are some very complicated patients out there that you need to try stuff with. But I don't know whether there's outcome data about increased prevalence or increased risk. My assumption is that those patients are at increased risk the way any polypharmacy patient is. But it's interesting. I'd love to take a look and see if there's anything out there in the literature.
Thanks. And then, and I will just mention, these are great questions. They're also really great questions for our consultation lines, either Max or BHIP. So if you have patients that you're wondering about kind of specific clinical applications, you can always call and talk to Dr. Fishman or any of our other physician consultants. We will maybe take one or two more. I know we're sort of just edging over time. What are your thoughts on using mirtazapine or bupropion for treatment with stimulant disorders or abuse?
Yeah, and my apologies broadly because of my tech problems. We didn't get the prescription stimulants, and so that we may want to reschedule a full conversation about that another time. But just real quickly, bupropion is a very useful treatment for attentional problems, either as classic syndromal ADHD or as attentional problems accompanying affective disorders. Now, they're not as potent as stimulants. They don't work in everybody, but especially in patients with comorbid SUD or comorbid affective disorder, they can be very helpful as non-stimulant alternatives. A whole nother conversation is that there is really a very considerable role for the treatment of ADHD with stimulants in comorbid ADHD and substance use disorder, and there's some outcome data about that in youth, but it isn't trivial, and it requires heavy lifting in terms of monitoring, supervision, and vigilance for outcomes and for problematic outcomes, but it can be very helpful. Just me personally, I probably stop more stimulants than I start, but I certainly start stimulants and treat patients, young patients, adolescents, and young adults with ADHD and active substance use disorder with stimulants. But you got to be on top of it, and you've got to make clear the goals of treatment that include concurrent SUD treatment and contingency for reductions and eventually stopping substance use. And that can be, a way of making the stimulant treatment more safe, more successful, and also adding the contingency if that treatment is desired. Well, then part of the cost of entry is you have to reduce and then stop your substance use. Let's see if we can have a win-win for everybody. But that would be another longer conversation if we ever do that session on prescription stimulants. Mirtazapine, very helpful medicine. As you know, it can be good for insomnia when comorbid with ADHD and or mood disorder. It's also a very good antidepressant. So I endorse giving it a try in the tool chest of the mood medicines.
So quickly, Mark, I'm going to make just a general answer a question, may be helpful for others, but I see at least one person who's interested in getting the X waiver. We're really pleased to hear that. You heard Dr. Fishman say earlier that while there seemed to be some progress in responding or kind of reducing the number of overdoses, that has since really gone in the opposite direction, and Max in particular is focused on trying to get more folks waivered and respond to the opioid crisis, but also can help with other substance use disorders. So any prescribers that are interested in that, Bridget just put the link for our upcoming half and half waiver. If you're just interested in getting your X waiver under the new HHS guidelines, you can call our phone line. But Rebecca, we can be sure someone reaches out to you if you just want to do that over the phone or over video. Just takes about 10 or 15 minutes max. So we'll be sure someone on the Max team reaches out to you, Rebecca, but the link is there if you want to do the full half and half, or for anyone else. And then just maybe a last question, and for folks we did not get to your question, we can be sure a consultant reaches out to you, or we set up a consult or email you the response. A general question that came in, Mark, was, can you speak to just some general differences between treating youth or adolescents and treating adults?
Yeah, great question. And that's a discussion for a whole separate conversation, but it has to do with trying to do developmentally specific things for the developmental vulnerabilities of young people who have a foot in childhood and a foot in adulthood, who are struggling, with developmentally normative yearnings for autonomy, but that are usually ahead of their capacities, right? So I'm all grown up, I'm 18 in one day, or I'm 15 in one day, and you can't tell me what to do, and I know better, and I'm invincible, all the things that you guys know about. And so taking those things into account, working with engagement, and although it's not easy, working with families. I can't stress enough how much power there is and impact there is in the natural relationship and leverage and persuasion and authority of parental caregivers. Whether they actually are parents or not isn't the important thing, but it's people in that family support role who can learn how to use their leverage more effectively. When they first present to you, they're often up to their ears in alligators and in crisis don't know how to do it, but teaching them how to do it can be quite impactful. In general, you should expect worse outcomes with younger patients than with older patients because of the vulnerabilities that I mentioned. That's true across all of these disorders. They're just tougher patients to treat, and their endowment of coping strategies, most notably affective regulation, which is immature, and executive function, which is immature, make them more vulnerable and make their outcomes more difficult. But the good news is, if you keep them alive long enough, many of them will actually grow up, myelinate, and achieve maturity. So hang in there, because therapeutic optimism is one of our best tools. And then I'll just conclude with another plug for the Max service. If you guys have individual cases that you want a little guidance on or want to ask questions, just holler, and myself or one of the other folks will get back to you, as was mentioned. And it's a really cool service to have available here in Maryland and DC.
Thank you, Mark. We appreciate that plug, and there are no wrong points of entry. If you call BHIP or Max, we can always work behind the scenes to get you connected with the appropriate consultant. And I just will mention, thank you for sticking around. If any of you are interested in staying on right now to get your X waiver, please just remain connected, and Julie from our Max team will stick around with you, and you can spend 10 minutes right now walking through that process. So Rebecca, if you're interested in hanging on right now, please feel free to do that, or any other prescribers that are eligible to get your X waiver, feel free to hang on, and we will walk you through that. Everyone else, thank you so much for joining us. Dr. Fishman, thanks as always. This was really informative, and we look forward to seeing you at a future resilience break or webinar. Have a good afternoon.
Thanks, guys.